Awesome, thanks. Welcome back. I hope everybody has had a great holiday season. Or maybe if you don't celebrate the holidays, if you at least got some sort of break from college or work or whatever you've been doing, that I hope that you've had a great time. So I'm Stephanie. I am a fourth year medical student from the University of Iowa. Tonight we will be going over a case that has to deal with dementia. Okay, let's see where I can get the next. All right. Oh, this for some reason didn't, hold on. Let me stop my share real quick, guys. I apologize for that. This is, I think, the wrong version. 1 second here. Sorry about that. Okay. All right. And we're back in action from beginning. All right. So everybody hopefully has the soap note. Again, as always, you're free to fill this out as much or as little as you want. As we go through the case, I just want this to be interactive and fun. Hopefully you learned something new. There is a quiz at the end, as always, to get some credit, and I'll try to highlight the things that you need to know for the quiz. But yeah, otherwise we'll just get started. And since we're running a little behind time because I struggled a bit at the beginning, we'll just go over this one. Okay. So as far as the case goes, so some of the case details, there's like a lot of them. So I'll just read through it and read kind of quickly. I don't think it's really important that you know every little bit, every little thing. I just wanted to make sure that, you know, when I was writing this, that I was thorough and put in like different details that we could talk about, but it's not important for you for the quiz or, you know, for your soap note to remember every single little thing. So Janice, we're in a primary care physician's office, and she's a 77-year-old woman. She's brought to the clinic by her 45-year-old son, John. She's here to establish care because she recently moved to Iowa City from a small town 2 hours away. Her son, John, says that Janice has been experiencing a severe deterioration in memory and cognition over the past 12 months. John and his sister, Sarah, who is a 42-year-old woman who lives in California, are Janice's only children. Both of her children have been concerned about Janice's mental cognition and agreed that it would be best for her to move into the guest room of John's house in Iowa City. Their father, Janice's husband, died of a heart attack 6 years ago. So to summarize, you know, it seems like we have this, you know, elderly woman being brought to clinic by her son because of some memory and cognition concerns over the past year. And it seems like that has caused her to have to move in with him to be better cared for. Okay. Oops. All right, so some questions to consider. So when somebody presents with memory concerns, quote unquote memory concerns, what are some key features you guys think you should ask about, or some key things that you should address? Do they know where they are at the moment? Yeah, absolutely. So maybe asking questions about, you know, what's your name? Where are you? You know, what year is it? Called like orientation, right? Oriented to person, place, and time. Wonderful. Great. Thank you so much. What else?
You could also ask them if they know who the president is, or do they know their names, what they do.
Awesome. Perfect. Yes, exactly. Some more questions just to get at what their, you know, their knowledge is, their basic knowledge of general facts. Great. Anything else? Okay, I'm just going to click and we'll go through. There's some other questions. So So really, when somebody comes in with any sort of, concern, chief concern, I don't like to call it complaint, but concern, you want to start broadly, right? Because some of these concerns are pretty vague, right? And non-specific. And memory can be one of them, right? So we need to dive in a little bit, but start broadly. So one thing that you can do is, you want to make sure that you get both the patient's view and the family's view. So you want to make sure that you ask John, this patient's son, from his point of view, what are the issues, and from Janice's, because they might not be the same, right? And then you also want to, ask about social history, biographical history, just meaning like, do they remember when their birthday is? Do they remember, the year their children were born, or the year they got married? And then any objective measurements of memory decline and the impact on activities of daily living. So there are different assessments that we can do and screening tools to see objectively what the measure of memory decline is. And then asking, has this impacted any activities of daily living? It seems in Janice's case, she's, had to move into her son's house. So, why has she had to do that? And then medical history is really important, especially medications, because, this could be a memory issue, or it could just be that she has a little bit of what we call delirium, which is just like fluctuating levels in cognition from maybe a medication change. So, having a very thorough history is really important. All right. So, what features of the memory decline should we ask about? Like, specifically, what about the memory decline itself should we ask her?
What type of things does she tend to forget?
Yeah.
So how often does she tend to forget things?
Mm-hmm.
Does she misplace anything?
Yeah, those are all fabulous questions. Exactly. So, I think that those are all wonderful questions, getting down to like the details too, because it's been going on for 12 months, but is this a daily thing, that she is struggling with? What is she forgetting? Is it just names? Is it just dates? Or is she forgetting how to do tasks, like how to go to the grocery store, how to drive her own car? Great. Anything else? Well, we'll talk about this. So, so describe the memory loss. As we were saying, is it specific details? Do you have trouble remembering past events or making new memories? And then at what time in chronological order do things begin to become hazy? That can be, a good thing to ask as well, because maybe they do remember all the way, back to when they were in high school, but maybe they don't remember, I don't know, from when they were married until now, or, it could be different gaps of memory that they're dealing with. So that's important to kind of pinpoint and get down. And then another thing too that's really important is asking about other aspects of cognitive function. So when we talk about memory, and a memory is just isolated, it might be something like delirium, or it might be normal aging where you're just kind of forgetful about things, or even, individuals who struggle with things like ADHD can have memory issues, or it can be a side effect from medication such as antidepressants. But somebody that's struggling with a neurodegenerative disease, for example, like Alzheimer's, it's not just memory. We tend to think of just memory, but it's also like cognitive abilities. So executive functioning, so higher levels of thinking, the ability to balance your checkbook and do things mathematically, or complete puzzles or things like that. All of that could start to decline in addition to memory. So it's important to ask those questions as well. And then why do you guys think maybe that mood would be an issue, or would be something you want to ask about?
Because if it's a mood, then it might be depression or anxiety or another type of mood disorder or her medication.
Yeah, absolutely. So, in elderly individuals, especially, sometimes these memory concerns, that's the presenting symptom of depression. And, we brush it off and don't really recognize that maybe they're actually struggling with a mood disorder. So it's important to be thorough there as well in regards to their psychological health. Okay. And then we already kind of touched a little bit on this, but as far as like social history goes and then their medical history, what sort of things do you guys want to ask?
Mm. Have her friends noticed that her memory changed?
Mhm.
Activities does she like to do, or does she do
Yeah.
any friends?
Yeah, great. Getting some more collateral history would be great. Yes, awesome. And then Adam had said medicines. Yeah, great. Has she started taking anything new recently? Or have there been any dosage changes or even maybe even stopped anything? Bridget has said any family history of memory concerns. I think that's awesome as well. What are you getting at there, Bridget, with family history?
Mm.
Maybe like I think Bridget's trying to get at the fact that some of these memory and even neurodegenerative diseases can be familial. It can have a genetic component.
Yeah,
Great. That's important too.
I thought that maybe a family history might be nice because it might be nice to know if she had her family history, brain cancer or strokes.
Yeah,
That could
great.
also have her memory issues. Thank you.
Yeah, thanks for saying that. I think that that's great because, when we talk about the differential for memory concerns or any sort of decline in your cognition, stroke and, brain cancer or metastases to the brain are on the differential, right? We never want to forget about those things. So great. All right. Awesome. All good questions. Good job, guys. And so for social, we didn't get to that, but yeah, just asking about drug and alcohol use, that's always important. Educational and occupational history is super important too, because you want to know what this patient's baseline was, right? Like not everybody has the same educational background. And then even, asking if they're still driving, and then some of the hobbies they have and if they can still complete those hobbies. And then their past medical history. I think it's important as well to ask about recent illnesses, as well as medications, as Adam had said. Recent illnesses, things like urinary tract infections in the elderly can cause that delirium or that transient, fluctuation in cognition. And so, this might, if this is something that's more acute and kind of waxes and wanes, then it might be, that they have some sort of underlying illness. And then asking about, any urinary incontinence, fever, sleeping habits, and diet and exercise too, right? We know sleep and lifestyle things are very important as well. So making sure that those are at baseline and that those are, the patient has a good sleep routine and is eating a healthy diet and exercising regularly will help them in their memory. Okay, so let's learn a little bit more about Janice. So far we just know that she's had these memories concerned for the past year and she's recently moved in with her son. So upon providing the history, Janice says, I do know I have some memory problems, but this is just because I'm getting older. Only my short-term memory is an issue. Sometimes I forget where I put my house keys or what I need to buy at the grocery store. She's able to give a moderately detailed biographical history, but she struggles with details extending as far back as the year of her wedding, the years her children were born, and the main job she has held throughout her life. Her main hobby over the past decade has been completing crosswords. However, over the past year, it's progressively taken her longer to complete them, and now she's only able to complete about 25% of the puzzles. Her son, John, had been visiting her frequently over the past 6 months before she moved due to the concerns. He says, one time she was supposed to travel to our house to visit the grandkids, and I called, but she had been driving around her town for 2 hours because she forgot how to get on the interstate. He has since taken her keys and advised her not to drive. So what do you guys think about this as far as the memory concerns from Janice's perspective versus John's?
It seems like there's a discrepancy. Like she doesn't seem too concerned about it, but he seems to be more concerned about it in terms of like, yeah, like her daily living function is sort of decreased, or that it's not safe for her to be on her own as much with the driving and her forgetting her things and not being aware of her memory for long stretches of her life.
Yeah. Right. Yeah. Do you guys think that, Janice, do you think that she might be, overestimating or underestimating her ability to remember things, or, the cognitive issues that she's having? Does she seem as concerned as John? Yeah. Late Alzheimer's is what it sounds like. Yeah, it really does, Adam. And what particularly about um late onset Alzheimer's, or about this case? She seems confident in what she remembers. Great. Yeah, so Adam pointed out something that is really important, and we'll get to this when we talk about the difference between, like, dementia and cognitive decline secondary to, pathological things like neurodegenerative diseases, of which one is Alzheimer's, and normal aging. In normal aging and things, when you are forgetting, little details of things, people seem to be, more concerned with that, right? They're like, oh, I'm concerned because I'm not remembering the things like I used to. And they're very aware of it. Whereas in, things like Alzheimer's, patients are often pretty confident still in what they remember. They're not as aware that they're forgetting things. And they brush it off as not being much of an issue. So, hear how Janice is saying, like, yeah, only my short-term memory seems to be an issue. But as we ask her more about her details of her life, she actually is not able to remember them. And then, of course, her son John gives additional information that suggests that it's more severe than she's letting on. So that's an important thing to notice here with this case. Great. Good job, guys. Okay. So then just a little bit more. John shares that Janice is a retired professor. She worked at a liberal arts college in Iowa for 35 years. She has a PhD from the University of Wisconsin. She's been very good with numbers, but she's recently had to let her son John take over managing the bills and the checkbook. Looks like she just has some type 2 diabetes. A1C was within the normal range a couple months ago. Does anybody remember what A1C is?
Yeah, that would be your blood sugar, and if it's past a certain threshold, it indicates diabetes.
Yeah. So A1C is a good way to, over the past 3 months, it's a good way that it's a lab, sorry, not a good way. It's a lab that is a good way that we check for blood sugar levels over the past 3 months. And so your A1C, usually around that threshold 6.5 to 7. 7 is really, really where we are diabetic. 6.5 is kind of pre-diabetes. You want it to be under 7 or under 6.5, usually, if a patient has diabetes. So it looks like hers is, well controlled at this time. We'd like to get a little bit lower too, but it seems like it's well controlled. And she's just taking metformin, which is, a diabetic medication. Doesn't look like she's on insulin. And then she takes Benadryl intermittently for allergies. She says about twice per week in the winter and spring. So family history, looks like her mom and dad are both deceased. Her father died of old age and her mother died in her early 70s. She had some memory issues as well. She doesn't have any siblings and her 2 children have no medical problems. Social history, as we said, she was a college professor with a PhD. She's never smoked. She drinks 1 glass of wine per week. Recently stopped driving. She doesn't exercise regularly. She was married for 40 years to her husband, who died 6 years ago by a heart attack. And then, as you know, she has 2 kids and 3 grandchildren, all of them from her son, John. And when we ask her about the names of her grandchildren, she can't remember them. Some additional history, since she wanted to ask about, recent illnesses and things like that. Doesn't have any recent illnesses, no fever, no urinary incontinence, sleeps well. She does eat a healthy diet, but John says that he has to help her remember to eat. And recently he has begun having to help her shower. Her mood is generally positive, and John hasn't noticed any signs of depression in the patient. So what things, I know this is a lot of information here. Of course, you don't have to know all of this. This is just to give, more thorough context on this patient. Are there things that stick out to you in this history that may or may not be related to what's going on. Her mother had memory issues too. Yeah, great. So perhaps this could be something, genetic. Anything else? Not exercising doesn't help with overall brain health. Yes, absolutely. So this is important to note because as we get to where we are making our recommendations, irrespective of what is causing this memory loss or cognitive concerns, irrespective of the etiology, she needs to be counseled on, regular exercise because that is great for brain health. And that's a good lifestyle change that she can make that can, help to lessen her symptoms. Gwen has said she needs to help to remember to eat and shower. Yeah, absolutely. So those are like activities of daily living that we call them, that she now needs help with, right? So that's suggestive of maybe, this is more serious than she was letting on. And that's, I think too, when we get to where we talk about like the DSM criteria for major like cognitive decline or major neurocognitive disorder, part of that is, disruption in your activities of daily living or having to have help for them. So this is an important thing to keep in mind from this patient. And then I think some other things we notice is just adding to the whole idea that this is more serious. So has her PhD in math, but is now having her son manage her bills and checkbooks. So that's concerning. It looks like she can't remember the names of her grandchildren, that sort of thing. Great. All right. Oops. Okay. So at this point, what are some differential diagnoses to consider? I want you guys to think broadly. We've already talked about some. I think Adam had already mentioned Alzheimer's. So let's talk about Alzheimer's really quickly. I think that should be on the differential, especially when memory is a concern, because Alzheimer's is actually very common in the United States. It's the sixth leading cause of death in the United States. So Alzheimer's falls under the category of neurodegenerative disorders. Sorry. Sorry, I apologize for that. That was supposed to show up first. But anyway, differential for memory loss, neurodegenerative disorders is what this is supposed to say. Alzheimer's falls under that category. We also have Parkinson, Lewy body dementia, which we'll talk about, frontotemporal dementia, vascular dementia, things like that. What other things besides neurocognitive or neurodegenerative disorders fall under our differential for memory loss? Yes, great. So MS, yeah, multiple sclerosis or traumatic brain injury, awesome. I don't know if I have those ones on here specifically, but those are both great and should be on the differential for sure. Yeah. Has she been injured, to a point where her brain has been compromised? Or does she have multiple sclerosis, which is a demyelinating disease, of which there can be areas of demyelination in the brain that perhaps it's in, areas of the brain which are involved in cognition and memory. Adam says brain cancer. Yeah, absolutely. So either a primary brain cancer and or metastases to the brain can definitely disrupt memory and cognition. Or even, asking, if this is obviously we would know for this patient, but she's if there's a patient who is currently undergoing things like chemotherapy, radiation, that can definitely cause problems with memory and things like that. Anything else anybody wants to add? those are some big ones that are really good. What about, yeah, so stroke. Yep, great. Stroke or head injury. So when we talk about, vascular dementia, which is a neurodegenerative type of disorder, it can be from having essentially having almost mini strokes multiple times, and that can cause memory concerns. So having a head injury, having stroke. What cardiovascular risk factors does this patient have? Does she have any risk factors for stroke or anything like that? Lack of exercise. Yeah, exactly. So exercise can be protective against those things. Absolutely. And it looks like she doesn't have a history of hypertension, which is a really big risk factor for stroke. But she does have a history of type 2 diabetes, which can, be related to stroke and things like that. And having poorly managed diabetes or poorly managed weight might eventually cause hypertension, which can then lead to stroke. So all of those things should be considered. So let's look at some of these. So we had said cancer, great. And then other things like infectious disease. So there can be, like I said, UTIs, just a urinary tract infection, can cause something called delirium, which we'll talk about. Or you could have, meningitis or encephalitis. So inflammation of the meninges of the brain or the brain parenchyma itself because of some sort of infectious agent. Endocrine issues can even cause memory concerns, specifically low thyroid activity. So hypothyroidism, anemia can even present with that. And then having too much or too little glucose. And then psychological, as we have talked about, depression, even psychosis. And then nutritional deficiencies, vitamin B12 deficiency can cause memory concerns. And then even normal aging. So it's important to, have this on our differential that maybe this is normal. We don't think it is, right? Because we've noticed that, it seems to be pretty severe. But if somebody's coming in with memory loss, it might just be that they are getting older. Okay, so this is from an article on the resource AMBOSS. So they say think Dementias for common etiologies of dementia. I kind of liked this acronym. So degenerative, as we've talked about, emotional, metabolic, so even liver, kidney failure, and the buildup of toxins, endocrine, nutritional, neoplastic, traumatic, as someone mentioned, and then infectious, autoimmune, and stroke. All right. So what portions of the physical exam might you want to pay attention to for this patient? Keeping in mind the differential that you guys have come up with.
Like decreases in certain motor skills, like maybe trembling or like weakness in her hands or blurry vision.
Yeah, great. So a lot of those neurological signs, right? Doing a thorough neuro exam. And that might give us indication of, is something disruptive in, the tracks of her brain that are controlling motor or controlling sensory information. Adam had said mental status exam. Perfect. Yes. So mental status exam kind of going along with the neuro exam as well can help us, tell us, is she oriented to person, place, and time? What is her affect like? More into what is her mood like as well? Isabella said list of words to repeat. Awesome. Yeah. So a list of words to repeat can help us give us insight into her short-term or working memory. So if I said, hey, remember, ball, bat, and pancake, I'm going to ask you those 3 words in 5 minutes. And if in 5 minutes I can't recall ball, bat, and pancake, then, that's not a good sign. Great. And yeah, cranial nerves. Adam had said cranial nerves as well, which is important for, giving us insight into if we thought this was a stroke or something, we would expect our cranial nerves to be compromised, perhaps if this was in a specific area of the brain. So yeah, neurological exam, mental status exam, gait exam. So even watching how she walks, because if we're thinking this could be neurodegenerative and maybe something associated with like Parkinson's, does she have a tremor? Does she have issues with gait? Cranial nerves, psychological exam, which also goes with the mental status, and then even hearing, right? Making sure that she is able to hear appropriately. So elderly individuals, you know, as you age, you naturally have a decline in your ability to hear. But if this is something that can be, you know, fixed, or it can be improved with like hearing aids, and obviously we want to do that because maybe her cognition is actually intact, she just can't hear what's going on. Okay, so I want to give you guys a minute to look at this, kind of read through it, and then let me know what you think.
Outside of his respects to his family, his life shared a story about him talking to his children on the phone.
So what do we think about the neurological and the mental status exam?
Yes.
Concerning?
Yes.
Oh, yeah, concerning. Are you, I'm sorry. Yes,
oh,
yeah, it's concerning.
Okay, let me write that down.
Oh, I think somebody's on the phone. I'm sorry. I need to mute someone.
768.
Mute. Okay, sorry about that. So yeah, the neurological exam, mental status exam is a little concerning. So she's not able to recall at 5 minutes 3 things that they've been asked to say. So how Isabel had said is a good way to test memory. Yeah, Adam has short-term issues. Great. Yeah, she can't recall certain things. And then even, you know, she's not oriented to time. So she says the year is 2010. And it looks like her hearing is slightly decreased in the left ear, but the son says, you know, this is chronic things. Yeah, retrograde amnesia-like, right? So Adam, what do you mean by like retrograde? Yeah, she thinks it is 2010. So she thinks it's in the past. So like, and when we have issues with memory, when we have like retrograde, that's like the inability to remember things of the past, whereas anterograde is an inability to make new memories. So yes, as Adam has pointed out, her timing of the events are off in the past. And we've also seen that from the history where she was unable to state, you know, when her children were born, or when she, or the job she had, or what her wedding was. All right. Oops. All right, so the approach to dementia workup. So as we've done, we want to take a detailed history. We want to do a good physical exam, paying close attention to the neurological and the mental status exam. And then we also want to do things like cognitive assessments or neuropsychological testing. This can help us get an objective measurement of, you know, what is their memory status, their cognition status. And then do they meet the DSM-5 diagnostic criteria for dementia, which we will talk about in a couple slides. And then there are some studies that we can do, studies and or imaging to identify the etiology of the dementia. Do you guys have any ideas of what labs we might want to do?
fMRI or MRI?
Yeah, so that would be an imaging test. Great. Yeah, an MRI. I think that that's helpful, keeping our differential in mind. doing imaging can help us look for things like, old strokes, obviously brain tumor. It can tell us about the atrophy of the brain that has taken place. So like the brain volume shrinks over time, but is it shrinking more than one would expect at this age? So things like that. An MRI could be very useful. What about what other things with labs when we're thinking about our differential, which was, remember, endocrine issues, nutritional issues. What else had we talked about? Like maybe a urinary tract infection. So keeping those things in mind, what are some things we might want to order for labs?
A blood test and a urine test.
Yeah, great. Blood test, urine test. Overall blood workup is what Adam said. Yeah, great. We want to check her thyroid, right? Might want to check some vitamin levels. See, someone said CMP. Yeah, so complete metabolic panel is good. Remember that metabolic issues themselves can also be the etiology of memory concerns. So like liver toxicity, kidney and toxins and things like that. So doing a full workup with labs could be very helpful. Yeah, so Isabel had mentioned a lumbar puncture, which can test like the cerebrospinal fluid. When we are concerned about, things like meningitis, even like multiple sclerosis, you can look with certain, like they're called oligoclonal bands in the CSF. So the CSF is like the cerebrospinal fluid around the brain. It kind of washes the brain area, cleanses it overnight. It brings in, immune cells and things to the area and is in contact with, the blood-brain barrier. I think in certain cases, perhaps an LP would be indicated, but usually in the general workup of dementia, it's not. There are less invasive things that we can do first to try to determine the etiology. But certainly if we are more suspecting, an infectious cause or maybe some sort of demyelinating disease like MS, then that might be indicated. But great for thanks for bringing that up. Okay, so yeah, labs, vitamin B12, our TSH, our thyroid stimulating hormone can tell us about the activity of our thyroid. Our CBC can help tell us about like anemia, or even if we are concerned she has an infection that's just not showing up in like systemic signs, we can look for, elevated white blood cell count, urinalysis, and then a brain MRI. Okay. All right, so let's just pause to do like a quick learning point intro to dementias as a whole. So we've been talking about dementia this whole time. I think it's a term that is actually known as major neurocognitive disorder. And it's not specifically like memory loss is not equivalent to dementia, okay? So dementia is an actual like diagnosis known as major neurocognitive disorder. That's a disorder of cognitive function, commonly caused by impairments in memory, language, attention, executive function, social cognition, etc. So not just the domain of memory. I think that's important to know. Most forms of dementia are associated with older age. However, the most common pathological causes of dementia include neurodegenerative and vascular diseases. Okay, so dementia, having all these impairments in your memory, etc., can be caused by multiple things, but the most common causes are these neurodegenerative disorders, so like Alzheimer's, and then vascular disease, which we have talked about, stroke. So to diagnose dementia, this is very important, and I want you to remember this too, is to diagnose dementia, you must rule out causes of delirium, which we'll talk about. They are fluctuations in cognition, or reversible causes of dementia. Essentially, you have to say this is not caused by something transient, like a medication change, or like this patient having an infection, or maybe somebody missing a whole night of sleep, right? It's not an acute thing. It's not caused by something that can easily be fixed. It's something that's actually occurring in the brain, and like there's actually something pathologically occurring within the central nervous system that's causing this memory loss and other cognitive dysfunctions. So all causes of dementia share impairments in cognition, but other clinical features can differ depending on the subtype of dementia. We have a question, I think. So dementia is more insidious, Adam said. Yes, awesome. Yes, dementia is more insidious than things like delirium, as we'll talk about. So patients in the hospital, especially elderly patients, are often at risk for delirium, just becoming a little like, confused, issues with memory, a little kind of loopy, so to speak, if they've been in the hospital for a while. And that can be just really common, right? But that doesn't mean that they actually have dementia or have these issues. It's just the nature of being in the hospital, being away from their home, having an unpredictable schedule, being woken up at 4 a.m. by the, med student who says, have you pooped yet? Things like that. So those are things that are not insidious, right? They happen quickly, they're fluctuating, we can fix them. There's like a known cause, that sort of thing. Dementia is more insidious. So there's an actual criteria for major neurocognitive disorder or dementia, which is the DSM-5 criteria. And it's listed here. So basically, you don't need to know all of this at all. I just wanted to, make a point that dementia can actually be the criteria for it can actually be met. And so one of them is that the cognitive deficits interfere with independence in everyday activities. So like I said, it differs from normal aging in that the patient needs, help with activities of daily living. And then, of course, you also have to rule out causes of deliria or reversible causes of dementia. So, question for you guys. Do you think our patient, let's assume that we've ruled out, we've gotten the labs back, we've ruled out delirium or other reversible causes. Let's assume that's been met. Do you think she meets the DSM-5 diagnostic criteria for a major neurocognitive disorder? What would you guys say? Yeah, so she isn't allowed to drive anymore per her son, right? So she meets that, the cognitive deficits interfering with daily life. I think they'd even said that she needs help with bathing now. And then, it seems like things have been significantly declining from her previous, right? She's had a PhD before. So yeah, we think that she does meet this criteria. So just a learning point here, and I think there's one quiz question which I'll be sure to point out what it is, but I just wanted to talk about the causes, the types of neurodegenerative disorders that can cause dementia. So neurodegenerative disorders, so actual degeneration of, parts of the nervous system, there's many different types. One is Parkinson's disease. You guys might have heard of this before. Dementia usually comes late. First, the movement issues come first. So a tremor, shuffling gait, etc. Huntington disease is an example of a neurodegenerative disorder. This is a genetic condition in which there's atrophy of the parts of the brain called the caudate and the putamen, and it can cause quote unquote chorea, what they call chorea, which is all these just random movements in space. They can't control their movements. They're overactive. So this is also one that, presents like Parkinsonism. It presents often with movement concerns first. Lewy body dementia. This is the one I think I made a point to include on your guys's quiz, but Lewy body dementia is actually, you can be clued into this being the cause of the dementia if the patient has visual hallucinations. So somebody also that their wife says that they, wake them up in the middle of the night because they start kicking them in their sleep. That could be an indication of REM sleep behavior disorder, which is also associated with Lewy body dementia. And then vascular dementia we talked about is a result of multiple strokes. We have this thing called Creutzfeldt-Jakob disease. So we're not going to really go into all of this too much, but it's like a prion disease. It's very progressive and fatal. The people usually die relatively quickly after, the symptoms arise. There's dementia associated with having HIV. And then there's Alzheimer's disease, which is the last one I'll just make a point to talk about because we'll talk about this more. But Alzheimer's is the most common cause of dementia in the elderly. And we'll talk about the pathophysiology to come. But when you think about neurodegenerative diseases that cause dementia, Alzheimer's should be, one of the top ones that you think about. Okay, so number one question to distinguish dementia from normal aging. We kind of already touched on this. Adam had mentioned that earlier on that, people who have dementia secondary to neurodegenerative diseases, for example, maybe Alzheimer's, they're less aware that they have memory issues and they're less concerned with it. In normal aging, people are aware of it and they tend to be more concerned with it. Additionally, with normal aging, activities of daily living are usually preserved, right? They're still able to function and do the things they need to do, whereas in dementia, they might need help. And so that's what these two paragraphs just say. So then I'll just talk about delirium for a second too. So normal aging and then delirium. So delirium, as I've alluded to, is that acute onset of fluctuations in attentions and levels of consciousness. So it occurs most commonly in older patients, and it's typically secondary to another medical condition or polypharmacy, being on way too many medications. So delirium can present similarly to dementia, but it is not insidious. It's acute and there's a cause for it, right? As I've already given an example of an elderly person being in the hospital. So differentiating delirium from dementia. So delirium is acute, dementia is insidious. Delirium is fluctuating, dementia, you have a gradual deterioration, so on and so forth. You can have delusions in delirium, which are short-lived. In dementia, you can have them, they can be more fixed. Possible causes of delirium, I want you to remember some of these, and we've talked about the medications before. Having a deficiency of vitamins can cause, delirium, having an infection, withdrawing from certain drugs, or having like a traumatic injury, or having toxins in your body. All of those are causes of delirium. So, question for you guys, is this patient taking any medications that can cause delirium? What do you think about her Benadryl?
Yes.
Yeah, right? So Benadryl it's called an anticholinergic drug and antihistamine drug. So it's used for allergies and things like that. That's why this patient is taking it. But because of its effect on the cholinergic and histaminic systems, Benadryl can lead to delirium and these issues with attention, memory, all of that in the elderly. So these days, if an elderly patient is having issues with allergies and really does need to be on some sort of medication, we would recommend something that is cleaner, like a second generation antihistamine. So Benadryl is a first generation antihistamine. The second generations have less of an effect on those systems, and so there's less of side effects. They tend to be tolerated better. So one thing we can do with this patient is recommending that she stop the Benadryl, and if she needs to take something for her allergies, she can take Claritin or another second generation antihistamine. Okay, so back to the case finally. So some results. So we had not talked about this yet, but in addition to doing lab work and doing the imaging, you want to perform a screening, and a screening for cognitive assessment. So the Montreal Cognitive Assessment, it's known as MoCA. It's a tool that tests complex attention, executive function, language, learning and memory, orientation, and perceptual motor domains. So we perform this on the patient. It takes about 15 minutes or so. And here's an image of what the test looks like. So just to give you an idea, what you do is you just walk through these different tasks and have the patient try to do them. So for example, this first one, you explain the rules and you say, you're supposed to draw an arrow from 1 to A, from A to 2, 2 to B. So you just alternate between numbers and letters. So obviously then B would be to 3, 3 would be to C, so on and so forth. And so depending on how well they do this, they get a certain number of points. Another example is like they need to name these different animals. You must draw a clock and then set it at like 10 past 11. And then there's other, cognitive tasks, such as like serial 7 subtractive from 100. So if they get 93, then, you can put a point there. If they get the next one, 86, they get another point, so on and so forth. So our patient had a score of 15. So this goes to 30. If you have less than 26, that is seen as abnormal. So remember that number. Less than 26 is seen as abnormal. The magnitude of how less it is than 26 suggests, mild, moderate, or severe issues with cognition. So she's 15, which suggests moderate cognitive impairment. So 18 to 25 on the test is mild, 10 to 17 is moderate, and less than 10 is severe. Okay, so then moving on to the lab results. So her complete blood panel came back and said that she had some mild anemia. In older individuals that can't have, baseline, just like mild anemia, you need to make sure that they've had a colonoscopy and had this checked out. It shows that she's had this chronic anemia for a while. CMP, her creatinine or her kidney function is normal. Her electrolytes are normal. Liver enzymes are normal. Her thyroid looks good. She's got good vitamin B12 levels, and her urinalysis is negative for infection. So here is her MRI of her head, though. So this is a T2 MRI that I'm going to show. The cerebrospinal fluid is bright, and the brain parenchyma is darker. So here's this one. So here, the reading said that there's a bilateral cerebral atrophy and prominent sulci. So the sulci and the gyri, the sulci are those like deep, indentations, and the gyri are like these little, squiggles of brain parenchyma is kind of how I describe them, for lack of better wording. So when you have severe atrophy, those can become, the spaces between those gyri can become very prominent. Okay. Here's an image again. This is just a little further down. So again, we're seeing this like atrophy of this generalized atrophy of the brain. And it looks like there's prominent fissures near the temporal lobe. So this is the temporal lobe here. If you can see how this is bright, so there's more like CSF in this area, that means there's probably a lot of brain volume loss in that area. And the CSF is filling where the brain loss is occurring. So temporal lobe. And then this is just a different image from a different view. So this says disproportionate atrophy of the medial temporal lobe and the hippocampus. So the medial temporal lobe and hippocampus are like right here. So right here as well. You can see how, so this would be the medial temporal lobe, hippocampus is kind of under. You can see how there's more of this CSF, this bright material here, because the brain has atrophied in that region. You have lost some of that brain matter. Okay. So we've already talked about like how she presented, but how would you guys summarize her results? Meaning like her labs, her imaging, and her MoCA test. First, what would you say on the MoCA testing? So she was found to have a score not of 18. This must be the previous one. I gave her 15, but she was found to have a score of 15. So remember, that was moderate cognitive impairment. What do you think about the labs? It looks like the labs are all normal. So what would we infer from that? Do you think her memory problems are caused by, something like delirium, where she has a nutritional deficiency, or maybe, an infectious cause? Yes. Yeah. Atrophy. So yeah, great. Yeah. So so the labs are normal, which indicates it's probably not caused by something like nutritional deficiencies or any sort of cause of delirium. And imaging, as Adam had mentioned, is notable for atrophy. So that's probably, where her brain, where all these issues are coming from. And it seems like, the radiologist had read it, and it was disproportionately affected in the temporal lobe near the hippocampus, which is an important area for memory, for learning as well. So are you guys concerned about a neurodegenerative disease? Yes, right. Okay, so yes. And this is because it seems to be progressive. And as I said, the reversible causes of dementia have been ruled out. She didn't have any findings of vascular disease on the exam. So what neurodegenerative disease are you maybe most concerned about? If you guys can remember back to the previous slides, we rushed through those causes of or those neurodegenerative diseases really fast, but what was like the most common one that you might be concerned about? Because it looks like she doesn't have any issues with movement. So Parkinson's, Huntington's, less of an issue. So yeah, Alzheimer's disease, great. Knowing that we're moving a little bit faster through these. Sorry guys, because we're getting close to time. We just had good conversation tonight. But yeah, Alzheimer's disease, let's talk about the pathology just a little really quickly. So I want you to know for your quiz that it's the sixth most common cause of the death in the United States. It's the leading cause of dementia. So you can't have early onset Alzheimer's disease before the age of 65. That's about 10% of the cases. And the clinical features are, what we saw in Janice, short-term memory impairment, insidious onset, language impairment, impaired executive functions, etc. And activities of daily living are affected. Sorry, somebody's police are like in the area, I guess, or the ambulance. Okay, and then pathophysiology. So this is also important to know. So we'll talk about this. I think there's a question on your quiz about this. So what causes Alzheimer's? So these plaques, and this is an example of a plaque here. These plaques are extracellular. So there's this protein called amyloid precursor protein. And it normally gets cleaved by a pathway that does not cause plaques. And that's just, enzymes, everything is working properly. But when there are these enzymes that cleave it in inappropriate positions, it can cause the formation of these amyloid beta strands, which congregate and form these plaques in the extracellular space. So these guys are in the extracellular space, and the formation of them in the extracellular space of the brain causes neurotoxicity, right? Because your brain's not used to having this just sitting outside of its cells. This causes neurotoxicity and then disrupts a lot of things, including like acetylcholine and the pathways for like learning and memory. And then we also have these things called neurofibrillary tangles. Now, these guys are intracellular. What happens with them is there's this protein called tau. It's an insoluble protein that forms like microtubules. You guys don't need to know that. But in Alzheimer's disease, it becomes hyperphosphorylated. And so hyperphosphorylated tau proteins form these tangles, and they're found intracellularly, and they also cause neurotoxicity. So these two things are, really heavily involved in the pathophysiology and can cause neurotoxicity. So amyloid beta plaques, they are extracellular, and then these neurofibrillary tangles are intracellular. And this was just a, depiction of what we had talked about with that, but you don't need to know that. And then, so going through this slide of diagnosis and treatment for Alzheimer's disease. So Alzheimer's disease mostly is a clinical diagnosis. You must meet the DSM criteria for major neurocognitive disorder, which our patient did. You guys had pointed that out. And as you guys had mentioned, we ruled out other causes of dementia or delirium. So her labs were normal. We checked on the medications, things like that. So you need to make sure you rule out that stuff as well. To definitively diagnose Alzheimer's disease, that would require like a histological prep of a brain section and seeing those plaques and tangles, which obviously you're not going to do in a live patient. So typically it's not done until, after the patient has passed away, like on autopsy. So really Alzheimer's, by definition can't really definitively be diagnosed until then. But we do diagnose it based on the DSM-5 criteria. And then treatment, currently there's no curative treatment. Management has to include things like supportive care. We had already mentioned Janice should exercise more. We should definitely encourage patients to engage in activities requiring cognitive function like puzzles. We also need to perform a functional status assessment for these patients, especially those who have like moderate or severe issues in memory loss, because you need to make sure that they can live on their own and be safe to live on their own. And if they can't, they might need help, right? And then we need to coordinate, whether that's living with a loved one or whether that's being placed in like an assisted living facility. There are a couple like pharmacologic therapies, but they don't really work too well. Some of these include acetylcholinesterase inhibitors. So acetylcholinesterase inhibitors are it inhibits an enzyme called acetylcholinesterase, which breaks down acetylcholine in the synapse. When you don't break down acetylcholine in the synapse, more of it is around, and that's supposed to help like the pathways of acetylcholine that are disrupted because of Alzheimer's disease. And then there are things called NMDA receptor antagonists, which decrease glutamate-induced excitotoxicity. So as we had said, the neurofibrillary tangles and the amyloid beta plaques cause this like neurotoxicity, and that can lead to, glutamate disruption and excitotoxicity. And these meds help to kind of counter that. But you don't need to know all of that mechanism or anything like that for your quiz. I just wanted to add that in there. So for the assessment and plan for Janice, you guys had said she met the criteria for major neurocognitive disorders, specifically Alzheimer's. So what happens, you have a lengthy discussion with both her and John. You're careful to allow time for emotional responses. Specifically for Janice, it can be very hard for patients to hear that they have a diagnosis like this. And you want to make sure that you're sensitive to that. And sensitive to the fact that, they might not fully accept this diagnosis right away, especially if they do have, all these memories concerns. So you counsel Janice and John on the importance of lifestyle factors, and then you also tell them to discontinue her Benadryl use. You mentioned the possibility of using medical management, but they want to hold off on that for now. And then Janice will return to clinic in 3 weeks, and she'll undergo a care assessment with like a multidisciplinary team, including you, an occupational therapist, a physical therapist, and a social worker. So this will help determine whether or not, she needs a higher level of care, like a supportive care facility, or if it would be okay for her to live at home with her son, John. I think it's really important for these patients too to be sensitive of their caregivers, right? There can be burnout, there can be caregiver fatigue for having to take care of loved ones. And it's really important for both in that situation, for both the patient and the caregiver to be on board about, what's the best plan of action and the best place for the patient to stay. Okay, sorry, that was a lot at the end. I kind of buzzed through all of that, but it was a lot of information. Hopefully you enjoyed the case and learned, something new. You guys did a great job at participating, had really good thoughts. So I do appreciate that. The quiz is available to you if you want to do that. I'm sure you guys will all do well on it. And you can get a certificate of completion. And then we'll see you in a couple Wednesdays. So not next Wednesday, but a couple Wednesdays from now, we'll see you guys again. Are there any questions or any concerns before we log off? All right. If not, thank you guys. Oh, yeah, somebody has a general question. Yeah, I can certainly answer a general question. I hope everybody has a great New Year's, though, for sure. Adam, what was your question? how did you find shadowing as a pre-med with doctors? I think that's a fabulous question. So I'll answer this one and then get to signing off. But any of you guys are welcome to email me if you have any questions. There are other resources on Motivate MD too to ask questions. My email, I will go ahead and just put in the chat. But then I'll get back to answering. This is just my email for now. I mean, it will be for like the next 6 months until I graduate from Iowa. But so how did you find shadowing as a pre-med with doctors? So this is a great question because I myself went to small liberal arts school. So there wasn't in a really small town. So there wasn't much opportunity for shadowing doctors. And I actually did not decide to go to medical school until like the last few months of my senior year of college. So I knew I'd have to take a year off because obviously, I was about to graduate and I had just decided to be a doctor, but it actually worked well for me. And the reason it worked well for me is because I had to take a year off to do things like take the medical admissions tests and things like that. And in the meantime, what I did was I worked as a scribe, and that helped me, immensely at understanding, the role of a physician and if this was something that I really wanted to do. So that's just something personally that, my story, which is, how I got shadowing, so to speak. Of course, I was working with the physicians, but scribing, helped me to see exactly what they did, helped me to be involved in patient care. I think it's a wonderful opportunity. However, I do understand that, that was sort of unique in the fact that I decided late to go to med school. So if you're currently like studying and you are going to like undergrad, or maybe you're doing a master's or whatnot, it might not be feasible for you to scribe. Maybe you could try to scribe, on weekends, or if you could make something like that work, because you get money for doing it. So that's always nice as well. But I understand that that's not necessarily feasible. So one thing I recommend is, depending on where you're at, just reaching out to, if you're at a university affiliated system or for school or something like that, it can be really helpful. Or people are always very, very welcoming and wanting to help pre-meds. At least that's been my experience. And so just getting someone's email contact information, asking politely, drafting a nice email to say, hey, I'm so-and-so, I'm really, excited about the potential to become a doctor. I would love the opportunity to shadow you for just a day, and willing to make my schedule work to whenever you have that availability. There are different, emails, things that you can look up online if you need help drafting an email to ask somebody to shadow them. But I personally just think like taking your step forward, and even if you're not at a university affiliated place, like maybe a community hospital is nearby, just getting someone's contact information and asking is really like the way to do it. It's just kind of go straight to the source, right? And I think it shows initiative, and it shows that you're really serious about it. And in more cases than not, people are going to be willing to have you come in and shadow with them. It might be harder to shadow in an inpatient hospital setting. Sometimes there are more like rules, especially in regulations, especially with like COVID and everything like that. But like I said, just ask around. I know it can be a little like scary, but it does, part of taking that step and like in showing initiative, are some of the skills that you're going to need, throughout your career and in medicine too. So this is a good way to practice, getting your foot in the door and getting to know different people. So that's what I would recommend. Sorry, that was like a roundabout way to answer that question, but hopefully that was a little helpful. That was more helpful. If you have any specific questions about like, your situation specifically, like, oh, I'm somebody living in this really like rural town and the hospital's like 3 hours away, we can brainstorm and things like that. But really just, finding somebody and just asking is kind of the way to go. Yeah, great. Yeah, you're welcome. The scribing 100%. I think that that's a great way to get exposure to the medical field. Additionally, the thing I'll say about scribing is I liked it because I actually got to see every day what a doctor does, and I realized like even as I was studying for the MCAT and things like that, like I didn't actually know what a doctor did. I just was kind of like, oh, okay. And like scribing was amazing because it just actually was like, okay, I actually want to do this, right? Because you don't want to sign up for med school, take all of those loans out, and then figure out that you don't actually want to do it. So definitely am a huge proponent of that. And then, yes, I actually scribed for a family med doc and it was wonderful. More laid back. I could do a lot more. I got to see, and participate more as almost like somebody shadowing or like a med student that was rotating. So it was really great. But yeah, okay. So I'm going to sign off, but thank you guys so much again. Thanks for the questions. And we will see you in a couple weeks. Bye-bye.